to say welcome to Anita. I would also like to say welcome to Anita Wester. Anita is a research fellow at the Australian Health Services Research Institute, which sits within the University of Wollongong. Anita was instrumental in the development and testing of the AN-ACC funding model. So welcome, Anita. Thank you very much for joining us this morning. And of course, you will all know Janelle White. No, maybe not. Janelle White is the Quality and Education Manager for PACOP. Let me introduce myself. I'm Claire Johnson. I am the National Director of PACOP. Welcome to you all this morning. But before we get underway, I would like to acknowledge the traditional owners of the land that we meet on today. In particular, I would like to acknowledge the Awabakal people where I'm recording from in Newcastle. And I'd like to pay respects to their elders past and emerging. So welcome to anybody from our traditional owners. Before we start today, because of our numbers, we have some alternative housekeeping. So because of the response, we've had to change to a webinar format. That means everybody who has come into the meeting today, your cameras are off and you are muted, so we can't see you and we can't hear you. Sorry, guys. But that doesn't mean that you can't participate and ask questions and get responses to the things that are really bothering you. We have a Q&A section that you will see will be available to you on the webinar screen. That will be monitored throughout our meeting. And after our presentation, we will have that opportunity to start looking at those questions and responding to them. One of the features of the Q&A section is that if somebody already has put in a question that you're really interested in and you think, oh goodness, we're not going to get a response to that today, can you feel free to upvote it. So I say that you like it, and the more likes, the more likelihood that that question will be one of the priority questions at the top. In terms of priority, we've extended our usual morning tea talk from the 30 minutes that we usually allocate to 60 minutes today. We're hoping that we will get through everybody's questions and everybody will be able to go home with all their questions answered. But unfortunately, if we go beyond the 60 minutes, we will have to respond to those questions individually to people by email. So on that note, I'm going to hand over to Anita. Thank you very much.
Well, actually, it's me first of all. But
Janelle, you go right ahead.
This is just an overview of what we're going to cover today, what we hope to cover. Anita's going to talk to us about the development of AN-ACC, the components of AN-ACC, and give us an overview of the benefits of AN-ACC. I'm in the middle talking about how PACOP aligns really nicely with the AN-ACC. And at the end, we're going to have our expert Rob speak to us about all things assessment and about the assessors themselves. And he will also all of us will be available to answer your questions at the end. Over to you, Anita.
Oh, good. Well, good morning, everyone, and thank you for inviting me to attend this morning. As Claire and Janelle said, my name's Anita. I'm actually a registered nurse, trained a very long time ago, but I've worked in government as well as prior to working in at the University of Wollongong. So in terms of our role, what the University of Wollongong did, we initially in 2017 were asked to conduct a review of the ACFI. The government contracted us to do that. And we concluded, based on the evidence, the research and the data analysis, that the ACFI was no longer fit for purpose. That was for a number of reasons, which you can read our reports about that. I won't go into that detail at the moment. So then we recommended a new study, a resource utilisation and classification study, to develop a new case mix funding instrument, case mix classification and funding instrument for aged care residential. Within that study, we had 4 expert clinical advisory committees. A lot of the work we do here is collaborative. Our role here, our approach to research is very much about a collaboration with the end users, with the sector. So we had 4 expert clinical advisory committees. Throughout the studies, there were 5,000 independent assessments undertaken. We had time and motion studies, or not quite the time and motion, but basically activity measures of 1,600 staff. And we also gained the data, accessed the data of 110 aged care homes, financial data. And so from that, we were able to really get a good picture of, firstly, the client, the resident nature, the clinical nature of the residents, and as well as the day-to-day activity that's undertaken in residential care, and as well as the financial costs associated with delivering that care. What we found was that diagnosis per se is not a cost driver, and that's a really important finding, because for a lot of people, and me included at the outset, I was thinking, where does dementia fit into this? But it wasn't so much diagnosis that was the diagnosis of dementia that determined the cost. It was very much driven by the care burden, how the individual presentation or the effect of that diagnosis on the individual, and therefore of the care needs they require. And we found that the major costs were end-of-life needs, frailty, functional decline, cognition, behaviour, and technical nursing needs. And they could be all due to more than one diagnosis, for example, a mix of dementia and mental health, or physical frailty and dementia, etc. Next, yeah, thanks. So the first thing to know about the AN-ACC, the Australian National Aged Care Classification, is that it's a case mix study. So it's a mix of cases, and that each of those AN-ACC classes have similar resource needs. So you might have people with different health or diagnoses within each class, but the resource needs, the needs of staff, what staff are required to, time staff are required to spend with those residents are similar. It's not additive like the ACFI, and I think that's a really important distinction to make. Within ACFI, we had a lot of people, you had to score, you get your high highs, and everyone was trying, and given the context, the historical context of aged care funding, which was certainly recognised in the Royal Commission and certainly has been acknowledged by this government, there has been a history of poor, inadequate funding for the sector. And that has a number of consequences, but partly the focus within ACFI, it seemed that it led the sector to more focus on adding up your elements, adding up your assessments to actually get to a final figure. The case mix classification system works differently, and I'll give you a little bit of an overview about that. So there are 6 core elements to this classification system. The first, it focuses on assessment. And this is a big difference from ACFI. Actually, I'll just take a step back. In developing ACFI, or in developing the AN-ACC, we were really clear that we had heard the feedback from the sector that nurses in particular were spending a lot of time having to fill out ACFI forms, maximising ACFI, and weren't able to use their clinical skills to care for the residents. Part of the solution then was to separate assessment from the role of the care home. So if you separate assessment for funding from care planning, you allow specialist assessors with expertise in that field to undertake those assessments independent of the financial drivers of the aged care home. And we found that the feedback we had from the clinical needs groups or clinical expert panels was that was actually a real benefit for registered nurses in particular in aged care, because they often felt constrained by having to assess for care planning, but the overwhelming driver was about maximising the funding opportunities. So our first objective was to separate assessment from care planning, assessment funding from assessment for care planning, with assessment for care planning, which was done in the care home by those expert staff who know the resident, and assessment for funding undertaken externally. The funding element, there are three elements there. The first one is the one-off adjustment fund, and that's a really important addition to the traditional funding model, because we recognise that when a person comes into aged care, there are lots of things to settle in, to build your care planning right, to build your relationships with the family members, etc. And also there's great opportunities and incentive even to maximise the well-being of your residents. So if a resident is a bit deconditioned, having been at home for a long time or been in hospital for a long time, you can actually use that additional funding to improve the health status of your resident with the risk of losing your AN-ACC classification funding.
That's a huge win.
That's a big difference. So that's the one-off adjustment payment. Then we have the fixed based care tariff, and that's the sort of, that covers basically the cost of aged care homes staying open. So it involves all your shared care, what we call the shared nursing or shared activities, and that's things like the one registered nurse who's in or the one or two staff members who might be on night duty, who won't be delivering individual care, but they're delivering care across the whole facility. And then the variable price per day, and that is that individual AN-ACC class that the independent assessors have assigned that resident to. So that's really important because those two elements, fixed and the variable, actually comprise the whole of your funding, the whole of the bucket of funding. And whereas I think the financial vulnerability that many aged care homes used to feel in terms of their, if changes to ACFI funding occurred, or if your residents, you weren't meeting your targets or whatever, the aged care homes have approximately half of their funding already provided in that base care tariff. So the AN-ACC component is only approximately half of the amount of funding that you get from the government. So there are 9 sections of the assessment tool, but before we go into the details, the way we approached assessment was quite different to traditionally. What we developed this expression can do versus do, which is an interesting expression, but it really is about, so assessors assess an individual about what they're capable of doing. So if they're for instance in a hospital, we don't get them to try and walk upstairs to assess them, but we make an assumption the assessors make the assumption based on the care notes, etc., of what they can do. And similarly, but the only difference is in terms of the behavioural elements, the assessment does actually capture what the resident does do in terms of the assessment. So there's all of those 9 elements to the AN-ACC assessment tool, and they're fairly common to a lot of you, I'm sure. We might just move on, I think that's okay. I just thought I'd give you a little list of why palliative care is so important. And during the RUCS studies, we did assess all residents apart from those who were being provided with palliative care, because we felt it was inappropriate and unethical to intervene in that context. So what you're seeing here now is a mix of different care settings and the scores on the AKPS. So you can see that even without those residents who were in palliative care, in residential care, there was still a large number of people within residential care who had quite high palliative care needs.
Yeah, you can see that. Look at the high numbers there at 50.
Yeah, and that's pretty interesting. When you think about hospital palliative care, you would think are the most extreme. And these are using the same measure, the same AKPS that is used within our hospital systems, our community palliative care services, and we use that and compared that to residential care. So you can see why palliative care has been such an issue, and that we really appreciate the government responding in that manner to support something like PACOP. So this is what it looks like. And there are 13 classes, as we say. And the first class is admit for palliative care. We've pegged the amount of funding from class 1 to class 13. Class 13 is the highest level of need, and they're generally people who are immobile, in bed with complicating factors like who may be at high risk of pressure area care, or may have daily injections, or may have, but they need a lot more assistance. people who come into palliative care, as you know, into a class 1 are those who are automatically assigned. They have a care plan and I can't remember all the details, but they're automatically assigned into that class. And then, but the point of difference between there are 3 branches in that class, in that AN-ACC. The point of difference is around mobility, and that's backed up by the data. Intuitively, we know that makes a difference in the care needs associated with a resident, but this is actually backed up by the data. That so the 3 branches are independent mobility, assisted mobility, and the immobile, not mobile class. So we can go into that a little bit later if you want.
And Rob's going to take us through class 1 a little bit later as well.
So some of you have asked, what are the compounding factors? So we say, if we go back to the previous slide where we talked about a person who has who may be immobile without compounding factors and with compounding factors. Compounding factors are those additional, predominantly nursing related care needs that require additional care compared to someone without them. And these are the things like the ADL supports, injections, the risk of pressure areas, as I mentioned.
Obvious things that are going to take more time and more clinical care. Yeah, that's good to know.
So this is I mean, I was quite excited as a former nurse. Well, no, I'm still registered, but I always say I'm an old nurse, and people make fun of that, but it is true. I am an old nurse. But I think the AN-ACC is really important because it's driven from a perspective of ensuring equity in terms of funding across the system. And it is about, there's a couple of things about it. Yeah, so it also allows you to have a meaningful difference, a meaningful description about your residents. And again, it's not about diagnosis. It's about what does that class look like. They're a relatively homogeneous care needs for those residents in that particular class. And the assessment tools drive the attributes of those residents that drive their need for care. It's certainly not comprehensive. It's not designed for care planning. However, many of the tools that are used we deliberately based it on evidence-based tools to ensure that these could be translated to care planning. Again, it offers greater flexibility and choice for both providers and residents. And most importantly, the funding's based on the residents' needs, not prescribed care models. What we found and what we heard from many people was in ACFI, for example, physiotherapists were being allocated to their interventions were mainly restricted to massage and so forth around in order to for the aged care home to capture the physio pain assessment, sorry, and physios themselves found that incredibly frustrating because they were not able to use the full remit of their skills, but also it wasn't necessarily what the resident needed at the time.
And physiotherapists played a huge role in pain management. And for me, the AN-ACC model just seems so much more resident-centred and holistic in the way it goes about compared to ACFI.
Okay, we'll just move on. So the impact on residential care, I think this is the really wonderful bit. Well, I'm excited about this. When we developed the AN-ACC, we wanted to focus on enabling the aged care homes to better use their skill set, use the registered nurses, the enrolled nurses, the care workers, use your skills to care for people, to deliver, use your expertise in delivering that support for those residents. So by separating at the assessment for AN-ACC to external assessors, that actually frees you up to do that more focused care planning and caring. It also means that you don't have to do you don't risk losing funding if your resident changes status. There's no auditors that are going to come in and confirm the AN-ACC class because it's an independent accredited assessor who has determined that level of need. these issues there are clear reassessment protocols because we didn't want people to think again with ACFI, it's often about reassessment in order to get to the next class because of the context of that overall financial bucket. It really facilitated that sort of focus within aged care. What we want people to do is actually reassess if they are going to make a significant change if there's a significant change in the resident. And again, the incentives are it's driven by evidence-based care, not by the need for a facility to maximise its dollars or to meet the funding criteria. Recognising fully that the aged care homes do need to manage their finances and there are funding imperatives within aged care homes, but that shouldn't drive the care you provide for your residents. It's also responsive in that what the government has, the government's undertaken the shadow assessments, and that has helped determine what we call the NWOW, which is the dollar associated with the resident care needs for their daily care needs. So each year or however frequently, there will be future costing studies it's again been undertaken independently by the Independent Hospital and Aged Care Pricing Authority. So again, this is about having evidence-based independent assessment of the sector's needs, not based on a constrained agenda from within central government. And it, again, as I mentioned before, it gives certainty to an aged care provider. It allows you to, approximately half your money is already being catered for. So instead of it reduces the need for what we call cherry picking, where you try and you only admit residents that fill your particular funding model. And again, it allows quality improvement. You can actually compare classes. They are homogenous groups that have similar care, similar resource needs. So that's a fantastic opportunity for future quality improvement. Yeah. And also the last element is about the public reporting. This actually does allow for that star rating, for transparency of funding being allocated according to the needs of residents. And we can then, in the star rating system, be seeing how it's expended. Has that been that amount of money going into that facility for those residents of that class? Does that correlate? Or is there a big difference in terms of what funding is going in and what the needs of the residents are? So there's these external factors that are independent of government, that are independent of care home providers, that actually allow for a more evidence-based funding model.
I mean, I'm certainly excited. For us starting in this space, it seems like a much more equitable, fair system that really focuses and drills down on the care that is needed by the resident. And thank you so much for your work that you and the whole team did for this. I'm really excited about what it's going to hold.
And look, and to be fair, the government, was really, I think, really a fantastic step that the government actually stepped in to fund, one, the review of ACFI, and two, the development of the RUCs or the RUCs studies, because for so long, and again, as I mentioned before, I used to work in government in aged care policy, and nobody for many years wanted to know what the cost of care was, because there was this inherent, it's going to be too big, we don't want to know. So this, I think, does bode well for the future of aged care in terms of having it an evidence base, and two, giving you as aged care workers and providers the evidence to continue to work with government to better receive funding and resources for your residents. So
and thank you. Thanks so much, Anita. And actually, we're also grateful to the government because PAYCOP, the Palliative Aged Care Outcomes Program, we're the tantalising filling in this AN-ACC sandwich we're having for morning tea today. So we are the Palliative Aged Care Outcomes Program. We're fully funded by the Department of Health, and it's come out of the Royal Commission and the findings that they had there. that there is a need to deal with the palliative situation in aged care. So that's part of the reason why we're here. And the things I wanted to talk about, how the exciting thing is how PACOP does align with this new funding model. We had the luxury of sitting, PACOP sits within the Australian Health Services Research Institute. Anita's down the hall from me, which was nice. But we also sat alongside them as they were developing the AN-ACC, and we were aware of what was going on and the absolute work and research that went into developing this model, and the evidence behind it was really exciting. And so because we were involved or around when that was occurring, we were able to incorporate really important evidence-based elements into the program we hope to deliver. So PACOP has a simple aim, is to improve palliative aged care outcomes for all residents and their families in residential aged care through standardisation of care and processes. And so part of that also is we have 2 collections that we are seeking to embed into the almost 3,000 aged care homes in Australia, and they are the Profile and Outcomes Collection. And the exciting thing about, because today's about AN-ACC, I'm not going to explain the program, the collections in detail, but 4 of the clinical assessment tools that we use in our Profile and Outcomes collections align with the AN-ACC tools. So what does that mean? Well, that means that when you're writing, if for all the staff here that are working in aged care, when you're writing your comprehensive care plans and clinical notes, you're recording the scores from those tools, the very same tools that are used in AN-ACC. So that's going to be beneficial as well. The processes behind the Profile and Outcomes collections, in other words, how often assessments should be completed, absolutely inform comprehensive care planning. It also highlights when there are changing needs. And Rob will talk to you about that later when it comes to what qualifies for reassessment of an AN-ACC class. And so our natural processes and timeline of assessments will absolutely identify trends to staff in aged care when residents are having increasing needs and when it might be time for reclassification. And as mentioned, the natural result of the assessments that you do in the Profile and Outcomes, and remember, these are just really standardising what aged care is already doing. We're not adding to the workload, we're just standardising what's already happening, but it very nicely aligns with the tools in the AN-ACC. The other thing to mention as well is, as you heard from Anita, you can enter aged care for palliative care under AN-ACC Class 1. That's only upon entry. But even when that occurs, the PACOP Outcomes Collection is evidence-based standardised palliative care. So as soon as they enter, they can go straight into the Outcomes Collection, and all of that is taken care of through our protocol for assessment and care. And also, as mentioned, the processes behind our 2 collections, as in how often you assess and record the results from assessment, will absolutely identify trends and significant changing care needs. So you'll be that'll be easy to for the AN-ACC assessments when they come in to look at the clinical notes as well. Of course, they do their own assessments, but your comprehensive clinical care plans and notes can also contribute to informing that. So the shared tools that we have. So on the PACOP side here, you can see we have 6 main tools that are incorporated across our 2 collections. So we monitor symptom distress for residents. That's a resident reported assessment tool. We also, from the clinician's point of view, record specific problems, and that's severity. Pain check's also there for the homes that are using it. But the 4 tools that align are the AKPS, measuring performance, as Anita's already talked to you about. The RUG-ADL measures function of the resident. We have the Rockwood Clinical Frailty Scale, and that's also interesting because it measures both cognitive and physical frailty. And also there's the palliative care phase. Now the phase is embedded in the palliative care section of the AN-ACC tool. So as you're getting these assessments through naturally doing the profile and outcomes collection of PACOP, you're documenting the scores and the results from these. You'll have trends, and you not only record the score, but you record what does that mean for the resident. Yes, they've got an AKPS of 40, but that means. And so those clinical notes will be really important for AN-ACC assessors as they come in. The other really cool thing that our really holistic assessments that we have in PACOP is that they have additional questions that align with other components of the AN-ACC. For example, in the profile collection, we have specific questions that align with AN-ACC, talking about how do I identify, does this resident need palliative care? And so that really helps staff make those decisions as well, but knowing also it aligns with the AN-ACC questions. The other questions that are aligned about advanced care planning and things like that as well. So it's really exciting. And so that means, less work, more streamlined work. So overall, the last bit of this tantalizing filling in this sandwich is just a summary really from the team here at PACOP. So AN-ACC's coming, and I guess the reason why we wanted to hold this today is so that you didn't feel anxious about, oh no, they're throwing yet another thing at us in aged care, because aged care seems to be getting a lot of things thrown at it. But one thing we want to tell you at this time when you might be feeling overwhelmed is that standardization and evidence-based processes can actually reduce overwhelm, because you know where to go to, you know what's happening. So the PACOP and AN-ACC actually work together and can improve care. So our PACOP tools, assessment tools, as I've talked about, align with AN-ACC. The PACOP processes for when you collect those assessments are also helpful with AN-ACC, because they will pick up changing care needs and they will pick up trends. And also that informs your comprehensive clinical notes and care plans. And so, as mentioned, you don't just record the score, but you record what does the score mean for care in the home, for how we're going to care for this resident and improve their quality of life. And so those clinical notes and comprehensive care plans that you're already doing, our tools help bolster those, but also they will be very informative to the AN-ACC people coming in doing reassessment.
Yeah, and can I just say, like, the other thing is they talk to each other, and the focus of what they're talking to each other is around the resident.
Exactly.
Around the resident's needs. So you have a funding instrument that correlates directly with the care planning or the care assessment, as well as the care needs. And from our perspective, we see, at the end point, and I'm sure that that's for every one of you as well, the end point is, how do we improve the outcomes for the resident? How do we make sure that they have a better quality of life and as best we can? Well, these tools, this whole process has been designed to give you the tools, to give you the evidence base, to have a consistent and coherent story for your resident that aligns the dollars with the care that is required.
And I'm really glad you said that, Anita, because the other thing about, and PACOP too, our tools and our processes are resident-centered in that the resident needs that you've assessed drive care, not the other way around. So it's really exciting. That component's exciting. And also the fact that, we all know, like, I guess the data is a byproduct of the clinical care, but we all know in health, data is like dollars. And if you want to show evidence that you need help or you need more resources, you need the data sadly, but data for PACOP, yes, we do collect data, and we always call it's a nice byproduct of clinical care. And what we do with that data is feed it back to the aged care homes, and they can see demonstrable outcomes from their clinical care, and they can know areas they're doing well, but also know areas where they need to work on. So that's another byproduct.
And that data is really important, because, as I mentioned earlier, that the costing study actually identified the clinical complexity of residents for the first time, an evidence-based clinical complexity, which government has listened to. For only 15% are independently mobile, 1/3 are bedridden. This, it's intuitively what goes on in your care homes. But this actually provided the evidence, which was resounding, with a resounding impact. Government cannot deny that data. So, you know, again, data isn't only, I mean, it's not a scary thing.
It often gives a negative. It's a really actually a positive thing in this, a positive byproduct of clinical care. So I'm going to hand over to you now, Rob. Thank you for patiently waiting while you are finishing off this morning tea sandwich. Over to you.
Thank you, and thanks, Anita. Thanks, Janelle, for both of those introductions. It was really useful to go back and remember where we came from, Anita, and it's been a long process, but I think it's been worth it. I think we're now getting to the pointy end of obviously implementing AN-ACC on the 1st of October. It's been a journey, but it's useful to have a reminder about all the benefits that are coming from implementing AN-ACC. And I think also, Janelle, just a reminder that it's also worth remembering that, you know, while there is a class in AN-ACC for admission for palliative care is about a lot more than just class 1. It's about what happens for people while they're in care and as they become palliative, and that you do need to seek a reassessment for people who have an existing AN-ACC class when they become palliative, and that doing the right thing for care will mean that you have tools to request that reassessment, which I think is really, really useful. Thank you. So look, I'm going to give you a really quick overview of the AN-ACC assessment and assessors and the process. We'll leave plenty of time at the end for questions, because I think that's probably more valuable than me speaking to everybody. So just a quick reminder about the AN-ACC assessors. They are all registered nurses, occupational therapists, physiotherapists by training. They all have to have 5 years experience in caring for older Australians, whether that's in residential aged care or somewhere else that has relevant experience. And they all go through a 4-day training program before they are allowed to go out and assess. They have to do a test at the end of that training program, and that determines whether they can go out and assess by themselves straight away, or whether we want to partner them up with a mentor before they actually go out and do live assessments with people. We commenced the shadow assessment process in April 2021. We've done over 200,000 AN-ACC assessments since then. Obviously, there's been some people who've left care after we've assessed them, so we've got currently 165,900 classifications for assessments who are active in care at the beginning of August. And we've also done around about 8,500 respite classifications. Talking about reassessment and reclassification, we've received 10,000 requests for reclassification since we opened those. We've done about 5,500, and we're just still working through the remainder to get them done before the 1st of October. Noting that we've just got a priority on there's a few people who haven't had their initial AN-ACC assessment yet, so we're trying to get them done. It's been an interesting challenge. Obviously, everybody, I'm not saying anything that anybody here doesn't know, that, you know, COVID's made it way more difficult to do assessments. It's made it more difficult to deliver care. You know, we only go into facilities when it's safe to do so. If there's a COVID outbreak, obviously the assessors are not coming in. So it's just made scheduling more challenging, but we will get there. If we have the next slide, please, whoever's looking after slides. So this is just about the criteria for entry as a class 1, which is, you know, where you're coming into residential aged care for the first time to receive palliative care. So the first step is that when you're entering the resident for care in the Services Australia platform, you need to tick the checkbox that says that the person's entering to receive palliative care, and that triggers 2 things. It means that we don't send an AN-ACC assessor out to assess the resident when they arrive in care, and it also triggers us to ask you to put in the palliative care status form. That form needs to be completed by an independent medical practitioner or a nurse practitioner before the resident enters permanent care. They can enter respite care and be assessed in respite care by a medical practitioner, but the form needs to be filled in before they enter palliative care, so that we know that they're entering for palliative care. the form says that the practitioner signs off the criteria that Anita and her team put together for us, which is a life expectancy of less than 3 months and an AKPS score of 40 or less. The form also just has 2 other sections, which are that the resident declares that they're entering to receive, or basically acknowledges that they're entering to receive palliative care, and the provider acknowledges that they have the capacity to deliver that care to the resident. Initially, we were talking about having the provision of the actual care plan to the department when the resident entered for Class 1. We think that was probably an unnecessary collection of personal information about residents, that the department had no need to actually see the care plans of every single person who entered into care. So that's why we now have a form, but we can request the care planning documents just to make sure that they exist. So that's part of the function of making sure that the money is spent where it is supposed to be, that there is the ability for the department to ask for these documents on request. And the final thing is that the individual, as with all AN-ACC classes, you remain in the class until you ask for a reassessment. So, I know with ACFI there was, pressure around, if you've been receiving ACFI palliative care for more than a certain amount of time, the department would come looking and make sure that things were going on. With AN-ACC Class 1, there's a policy decision that you remain in Class 1. If you go into remission, that's great, and so you stay in that class until you leave care, or until you move to another provider. So, which could be that. And you just need to replace them, still relevant. I think. So the AN-ACC reclassification, I can talk through this again quickly. We've made a couple of changes to this from what was originally proposed by Anita and her team, and it's really around the care needs side of things. So the criteria for hospitalisation and time have remained the same. We received feedback from the sector around changes to mobility, and noting that there were times when people's care needs changed quite significantly without their mobility changing. So from 23rd of July, we've expanded the reasons that you can request a reassessment or a reclassification to include cognitive ability, compounding factors, function, mobility, and pressure sore risk. But the other criteria remain the same. If you are requesting a reclassification between now and 1st of October, I'll just let you know that the system, the health provider, so the My Aged Care system, hasn't picked up the new criteria just as yet. They will come live on the 1st of October when our system updates for the introduction of AN-ACC. There's just some technical reasons why we couldn't change those straight away. But so if you're requesting a reclassification on the basis of cognition or function combining factors, we just ask you to tick the mobility box, and then in the free text area where you ask where there's additional information about the request, you can put in that it's for cognitive ability or for compounding factors in that space, and we will do the reassessment. So the way that both assessment works in AN-ACC, as Anita said, it's an independent assessment. We have contracted 6 assessment organisations to do that. We automatically come out. We automatically send a referral to the assessment organisations when a resident first enters care, or when a provider asks for a reassessment, reclassification. So you have to do that request through the My Aged Care provider portal, other than for the initial assessment. So the assessment is always done after the resident enters care. It's not done before they enter care, and it's always done on request. I think probably the only other thing to note about assessment is that when the assessor goes out, they're assessing the clinical tools. They are not assessing the AN-ACC classification. So the assessor does not know at the end of their assessment which classification the resident will end up in. All they're doing is assessing the resident's clinical needs. That assessment data gets fed back to the department, and it goes through an algorithm on My Aged Care, and the algorithm is what actually determines the classification, not the assessor. So I think that's probably, unless we've got some, there's the references, and I'll sort of, I guess, hand it back to our hosts and questions.
Thanks so much, Rob. I just wanted to finish up on this references page for a little reason. The AN-ACC is causing, and given the sign up to our humble morning tea talk was over 200 people today, it really does show the interest in AN-ACC, and also to some it still remains quite mystical. So the reason we wanted to have today was to, one, demystify it, but also really highlight the actual, what I believe are the benefits of the AN-ACC, and it's a fairer system, it's resident focused, it's more equitable. So they're the two things I wanted to highlight. Plus I wanted to highlight there's probably a bunch of very expensive courses you could do to learn about the AN-ACC, but what I really wanted to highlight was that today was free, and there are a whole range of free resources on the government website available to help you understand all the components of AN-ACC. They're freely available. And I believe you even have webinars, Rob, that are you're sort of conducting that people can, so what I'm trying to highlight is this information is freely available and it's accessible for everyone.
And I think
Thank you. Yes.
I think that goes back to the culture of aged care funding that has sort of evolved over the last couple of decades prior to the AN-ACC, and that culture of people are resource constrained, and people justifiably in many cases needing to focus on how you maximize the funding available. But hopefully I think we've actually, that time has passed. I think the commitment to evidence-based distribution of funding, we've developed it in a way that could be that allows for equitable, sustainable and accountable resourcing in aged care. Again, the final decision obviously about the actual number of dollars that are attached is not within our remit, but we've given the infrastructure in order for government to do that. And I think the good thing is that we've seen a commitment from government to actually implement.
We've got about 15 minutes left, so I'm going to stop sharing. There's our email there if you want to email PACOP about and ask any further questions. I'm going to stop sharing now and hand over to Laura, who has been painstakingly monitoring the questions. Are there some interesting ones that are coming up?
There are some good questions coming up. I might ask some ones to do with the assessors that will be quick, if that's okay, Robert. One of the questions we've received is, are the AN-ACC assessors assessing residents prior to admission?
So no, it's always after entry. So as with everything, there's always like a star and an asterisk, right? So for permanent residents, the assessment is always after entry. For respite residents, there will be an assessment done as it is at the moment by the ACAT team. Instead of determining respite high and low eligibility as they do at the moment, they will do a quick DEMI, which is the mobility tool in the AN-ACC, and that will put the resident into one of 3 respite classes. So for respite, before entry, permanent after entry.
Right. And one of the questions that we had was about a respite resident. So they've had a resident admitted and they're going to be permanently admitted as a palliative class 1. And the question is, does the usual GP visiting the facility meet the definition of an independent medical officer?
Yes, as long as they're not an employee of the facility. So they can be a regular visitor to the facility, that's fine.
And one of the other questions we've had about assessors is, how responsive are the assessors when requesting a resident reclassification? How rapidly will this be achieved? And is the assessment multimodal, for example, face-to-face and online?
So the assessments are always done face-to-face, so that there will always be a visit from an assessor. The criteria that we are applying is that assessors need to go out within 28 days of receiving the request. Often it will be quicker than that. It really depends. What we're trying to do is bunch up requests in similar areas so that not sending assessors out a long distance for a single assessment, but they will where there are multiple requests from the same facility, they will go to the same assessment organisation, so that organisation can go out and do its assessments efficiently, if that makes sense.
And I think though, Rob, the other point to make is that it's not completely dependent on the AN-ACC class, that approximately 50%, and in some cases more, of your base care tariff, of your base care funding for an aged care home is already provided. So that the change in resource income that might occur because a resident is changing their care needs won't be as dramatic as probably would have occurred under ACFI.
Yes, I think that's a really good point, Anita. And the other thing is that, when we do the assessment, the payment at the new class goes back to the day that you asked for the assessment. So that, if it takes 2 weeks for somebody to come out, the payment will be back adjusted to when you initially requested the reclassification rather than when we turned up.
And Nina, I've got a question that you might like to answer. Someone has posted, noting the selection of RACs, how was the existing financial performance of the nursing homes taken into account? E.g., some are losing money now while others are very profitable.
So sorry, is that how was the RACs undertaken?
So just in relation to that 50% that you mentioned through the tariff, how has that been taken into account with, I guess, financial performance or resources for homes?
Again, look, we just looked at the status as it was at that point in time, and we did. But the sample of that we drew from was a representative sample, a mix of metropolitan, rural, and remote, as well, and across for-profit and not-for-profit providers. So it was a representative sample that we actually we drew the data from, and both similarly with the resident assessments. So I mean, I can't talk to what the current the funding situation for aged care homes at the moment, but I can say that the model itself was initially developed on that basis. The other thing to note is that with the Independent Hospital Pricing Authority and Aged Care Pricing Authority doing its costing studies, those things will all be on the table.
And look, I might just jump in there, Anita, and just put in a plug that I meant to say, which I did forget, was that so the legislation that brings the Hospital Health and Aged Care Pricing Authority in existence became law on the 12th of August, and the authority has actually already put out a consultation paper on its approach to aged care pricing. So it's probably worth, if you're concerned or interested in how it's going to go about its aged care pricing role, they're seeking input into that process at the moment. So it's well worth having a look and reading up on what they're thinking and how they're thinking about doing it, and taking your chance to have a say.
And can I just jump in there, because I do think it's really important that, again, the clinicians who work in aged care look at those documents and try and make time to have a look and review them and provide your input, because I think traditionally, again, as I said, that culture over the resource constraints over the last couple of decades has meant that predominantly financial managers, etc., are responsible for running, looking at all those things. But I think this is an opportunity for nurses to actually, sorry, I'm speaking as a nurse, but I think this is an opportunity for you to actually use your clinical judgment, and this provides a framework that values the clinical assessment and the clinical skills of your nursing and care staff. So
one of the other questions we've received is, does the nurse practitioner or a palliative care specialist have to be independent from the facility or the organisation to complete the Class 1 request?
Yes.
Yes. And Janelle, here's a question for you. Do facilities need to sign up for PAYCOP to be able to access AN-ACC funding?
Oh, no, AN-ACC funding for everyone. However, I would highly recommend everyone sign up to PAYCOP. I know I'm biased, but standardising palliative aged care is going to be wonderful for residents and their family. No no resident will fall through the gaps, and everyone's needs, it will improve quality of life as they approach end of life.
Yeah, and given around a third of, if you look at the data, about a third of residents die each year. We should be this is routine practice for many of you. But these tools give you the resources, but also the processes to ensure that for yourself that you're doing the best you can.
I mean, we do know that around 60,000 residents die each year in aged care, and it's not rocket science to the people who are signed up here probably, but it was the Royal Commission that highlighted this sort of information, and the rest of the world went, oh my gosh, people go to aged care and actually die there. We know that, and you're right, Anita, about 20% of those 60,000 will die within the first 3 months of admission, within 3 months of admission. So we need to get on top of palliative care, and palliative care, as we know, is about getting more life out of your remaining days, not getting more days out of your life. And that's what we want to do for residents. But the PAYCOP program also incorporates consideration of the family.
Yeah, that's right.
There's also been, sorry to interrupt you, I'm just trying to get through some questions before we finish up. There's also been some questions about how AN-ACC will fit with the auditing and accreditation model in aged care. Do we have any information that we can share on how that will work with that process?
Obviously, the auditing and accreditation is done by the Aged Care Quality and Safety Commission. The Commission is well aware that AN-ACC's coming in. They're getting the AN-ACC data coming through instead of, at the moment they get ACFI data and they use that as part of their risk-based assessment process. I think that they will use AN-ACC data the same way.
We've got about 3 minutes left, Laura. Have we got any burning?
There's a couple about the GP. Is the GP able to complete the status part A and B of the Admit for PALCare 1 forms?
So the part A and part B. So part A, I think, is I can't remember which one is which. That's the resident information and the details of the clinical assessment. Yes, that's fine.
So I think you broke up a little bit there, Rob, but I think the answer was yes. Great.
Thank you.
Yes, that's correct. Yes, sorry.
Yeah, right.
The joys of internet meetings.
Yeah, it's great when it's working well.
So there's been another question here. Does this approach apply equally to community and residential care? So Janelle, would you like to answer that from a PAYCOP point of view, and then we can throw to AN-ACC?
Sorry, I was reading the questions. Laura, what was that again?
One of the questions from earlier says, does this approach apply equally to community and residential care? So would you like to answer that from PAYCOP?
I can answer that from PAYCOP. So PAYCOP's remit for this first 3 years of our funding is to standardise and embed our program into residential aged care. I mean, watch this space, it may expand, but at the moment our focus is on getting palliative care and residential aged care standardised and improving the quality.
But it's important to know that the palliative care, this program is already being implemented in a version of it is being implemented within the community settings, not community aged care services not so much, but out of the hospital system and in community palliative care teams. They're using this data as well. They're using these processes, and they're the tools that have informed the use of the tools in aged care, in residential.
Yeah, our sister program is the Palliative Care Outcomes Collaboration, and they do exactly, we modelled off them, except we have feedback and we've changed our program to be appropriate for residential aged care. But PACOP is already doing this and has been doing this for over 15 years, over 15 years in hospital palliative care, community palliative care, hospice. Yeah.
Can't hear you, Laura. Oh, sorry.
You're on mute.
I said maybe one more question before we wrap up. Does PACOP have plans to train generalist practitioners, AN-ACC assessors or GPs in end-of-life and palliative care?
It's not our role to teach palliative care. There are plenty of providers such as LDAC and PEPA. There are other government-funded organisations who are happily involved in teaching and providing resources to learn about palliative care. PACOP is, we do have information resources for GPs and anyone who's involved, all the key stakeholders who are involved with PACOP. But our remit is to get into aged care standardisation of good quality assessment for palliative care. So we leave the teaching to, and we do refer a lot to the other organisations who are already funded to do that. So we don't want to double up or cross over.
Lovely. Thank you so much. It's 1:11, so we might stop there. I'd really like to thank Robert and Anita for joining us today for our morning tea talk. And our next month's morning tea talk will be on the overwhelm that a lot of our aged care homes are feeling next month.
Thanks everyone so much for joining us. Thanks Rob and Anita. We hope it was helpful. The recording will be coming to your inbox shortly.
Thank you.
See you later.
Bye.
Bye.
Thank you. Bye.